Great, thank you. So if you could sit in a place, maybe, do we not have a seat up here? You can sit here for now. Yeah, there's your name. So I'll start with one question. We have about 12 minutes for this phase of questions. And one is, I'll start with Joe, but Ira can add his experience. So both of you summarized very, very nicely the sort of spectrum of challenges and various benefits of the different models. What we want to make sure we get before the end of the day is wisdom from your experience with this. Yeah. And I know Joe's, Yoda is sort of, it's still in its early phases, but I'd be very, very interested in if you could just say a few words about why you've made the choices you've made so far, and any other comments you might make about the long-term viability of this. This depends on you and others being at Yale for a long time. And Ira as well. I don't know if you've had through the Parkinson's Consortium or whatever direct experience with this, but a few words on that would be very helpful.
Sure.
Just add a sense about the cost.
Sure. So the Medtronic experience is very different from the experience we're now engaged in with Johnson & Johnson. So that was we started it 2 years ago when no one was talking about data sharing, and it was really, the idea was to get people to the table and demonstrate that it could be done. And the biggest part, Jeff, just in terms of the cost issue, is that the experience with the Medtronic was that it wasn't just making the data available. We were going to do coordinate two independent systematic reviews and meta-analyses of the data prior to making the data available. I think that the important thing is, I think our models are changing, and what we're going to do with Johnson & Johnson versus what we did with Medtronic based on their interests in coming together and finding a middle ground that works. So when we were working with Medtronic, we convened a large stakeholder meeting. We brought in not just people from Medtronic and members of our steering committee who were providing oversight and giving us advice on how to do this, but people from industry, people from the open science world, and we really tried to come up with what we thought was going to be a policy that found the middle ground. With Johnson & Johnson, it's what we think is going to be a little bit different. I mean, it's just going to be a slightly tweaked based on their comfort and us pushing them to make the data as available as possible and coming together in order to make as much data available as we can.
So just to follow up on partly, but I'm sure we'll get other questions related to that. Whenever you get these models where you have the sponsor in some way, you said you develop the model in response partially to their preference. There's always issues of trust and access. And how are you balancing that in this particular example?
Well, with both organizations, both committed to making the data available based on our decisions, right? And so we're trying to establish a process that is fair, transparent, open, that anyone can have insight into and anyone can apply to the data for, but does put some boundaries around data access. So it's not just completely open. We're not just taking the data sets and putting them online. One of the, I think the biggest challenges we're going to have with Johnson & Johnson is they are fully committed to making all the data available, but that their data is not necessarily already in the format to just sort of click and make online. And so managing that process as requests come in and determining feasibility is going to be one of the biggest challenges I think we're going to have. It's going to be less about evaluating the scientific rigor of the proposals that come in. My experience with Medtronic and that is we get great proposals, great people wanting to do analyses. It's just the challenge of getting the data out there.
So one last question from me, and then we'll go to the others, and also want to hear from Dr. Schulson. And this relates to Jeff's. First of all, how are you deciding how much metadata goes with it, and what's the cost of maintaining it, and who's supporting that, and for how long?
Right. So the metadata that goes out is all the trial data, all the data dictionaries, anything that any novice user would need in order to make the data available. The support from Medtronic was originally for a year. They've already granted us a no-cost extension to continue making the data available for another year. This agreement with Johnson & Johnson is over the next 2 years. And so, but I expect, again, it will continue to be made available and go on forward. And did you ask explicitly about costs?
Well, yes. Is that public?
No, I mean, well, sure. The grant from Medtronic was originally, I think, approximately $1 million. I would say more than 40% of it went to the individual organizations we conducted to do the actual research on the data. And then we have not even spent the rest. So that's why they're continuing to make the data available, because our costs are limited and we're able to manage the proposals, and we can, and keep making it available through no cost extensions.
But again, this will depend, maintaining the platform depends on the continued funding of in this case, the sponsors, which in the situation we're talking about would have to be the NIH or other research funders. Isn't that right?
Right.
Okay. So, Dr. Schulten, do you want to chime in here, and then we'll go to Ida and
yeah, so I'll just share,
Dave.
Our experience has been with sharing data over the past 30 years in multi-center trials in Parkinson's disease and Huntington's disease. Half of these studies have been, it's interesting, have been sponsored by the NIH, where there are increasing obligations for data sharing. Actually, the obligations, of course, are for data sharing plans, and the implementation of these is still quite lacking. Also as a sustained support. So, for example, as we complete our multi-center trials and publish them, and there's that lag, and we hand over the data back to the sponsors, in this case NIH, that does not necessarily guarantee that the data will be shared. There's a turnover of staff and administrators and priorities at the institutes in which we work, and a lot of this gets lost. So what we've done in turn is to be able to share these data more widely, not just through NIH, but also through the foundations, of patients and families who have a real vested interest in this. So we have turned over our Parkinson's databases through the Parkinson's Study Group, for example, to the Michael J. Fox Foundation and the like, and the same thing we've done in the Huntington's disease area. I don't want to be absolute about it, but that's just in terms of a trend that we've had. Costs of data sharing are enormous. We're very interested in this. We actually having a paper come out on this, but the biggest general costs are human resources. There are administrative costs, and by the way, the administrative costs in relationship to institutional review board obligations or research participant obligations are enormous. Going back and reconsenting, staying in touch, they are really necessary, but I just want to point out that the catch-up on this is a big cost in terms of human resources to do. And this is in addition to the obvious courses like writing data dictionary, making sure it's standardized, responding to queries, more data sets. The response to queries from people who share your data, it can be enormous. It can exhaust so much time. And in fact, what happens also is there's an opportunity cost for that, because instead of data generating, you're spending time on data sharing, which is also good, but perhaps not as immediately rewarding as one does. We just, Aaron Wilhelm and I and an economist at the University of Chicago, Emily Oster, just finished an analysis of the ADNI project, Alzheimer's Disease Neuroimaging Initiative. It's not a randomized controlled trial. It's an observational study. Data are posted within 24 hours of access, including neuroimaging data. And we interviewed this has been running now for, I think, over a decade, sponsored by NIH, National Institute of Aging, the Foundation for the NIH, and a consortium of industry and foundations. And they estimate that their costs for data sharing are 15% of the total cost. They spent $100 million. That's $15 million cost.
I want to get a chance. So that was incredibly interesting. I just want to make sure we have time for our three questions, because we only have a few minutes. Thank you. So Ida, and then Joanne, and then Dave.
So speaking of costs, there are infrastructure costs, right? There are costs for data preparation, metadata preparation. There's costs for responding to requests. But, this being the controlled access panel, there are costs for adjudicating requests, right? So I'd be interested in two answers to two questions. One is approximately what percentage of your expenses go to adjudicating requests and responding to requests? And given that, money is tight all around, could you give us some insight into how you would decide when control of access is necessary? Are there situations where you don't really need to spend the money on controlling access? Or do you think that all of them needed to be controlled? So one question is what proportion of your expenses go to adjudicating requests, and whether you could, not have those costs for some subset of studies.
Thanks, Anna. That's a good question. So I'll say that has been one of the biggest challenges as we've sort of been working through the Yoda project is trying to estimate what our costs will be to manage the system, not knowing what the requests will be. And so with Medtronic, for instance, we ended up, I think over the past 6 months, there's been 12, 15 people who've registered for the single set of 17 trials, and 4 have submitted full proposals that have needed to be reviewed. So obviously that's a very small, requirement from our time perspective. But in the days since we made the announcement with Johnson & Johnson, I mean, we've gotten double that number of inquiries already. So I think it's just hard to know in terms of what the personal time effort is. But what we've tried to set up is or will set up is a very clear set committee of 4 or 5 different investigators, including a statistician, to be able to review those requests. And in terms of whether is data that doesn't need to be, I mean, as much data as we can make available, I think, is the ideal. And maybe we can all come to some sort of agreement when a data set's been analyzed 5, 6, 7, 10 times, it can just be put out there because whatever's there has been discovered and has been found. I don't know if there's any established metric for that.
Can we go to the Joanne?
Yeah, I was just curious actually for all the panelists. Okay, for all the panelists, how do the secondary analyses become transparent and available? It's clear that the primary data are out there, then people either go online in the open sharing networks or in the closed ones they put in a proposal. Then what do they do with their data so that science can be self-correcting, which is what I think everybody's hoping for, right? There'll be more analyses. Some of them may have some questionable analyses done, et cetera. But we're all counting on the fact that we can share those or see the secondary analyses. So I'd be interested for the open networks and closed networks as well, what you're doing.
So, I mean, we've taken the approach at Sage of making it really easy to share your secondary results. And so we have some contractual language in there, but we don't have the ability financially to, enforce and go sue people. And contracts are inherently weak. If someone breaks the chain of contract, reposts the data someplace in a place that's off the American shores, then our ability to enforce the contract is nil.
So you don't post it anywhere. You're asking them to post their analysis
and we make
somewhere.
it easy for them to post it, right? So because in many cases, either you have to have a relatively rigorous controlled system in which you know who the person is and you have the ability to contact their institution because they've acted badly, or I think you have to make it very easy for that to flow back. And facilitating contact between the participants in the studies is the other thing that we do. Under the thesis that the person reanalyzing who's talking to the participants will have a greater social bond that makes that resharing more likely. But it's very hard to force people to do that outside of a controlled system.
Not much more to add except, the publication venues are the other way to do it. Just straight analysis of a data set might not be seen as innovative or publication worthy, but meta-analyses putting data sets together typically could be.
I'll just add that in our agreement through the Medtronic data that we do require results be reported within 1 year of the data being provided access.
But reporting is not the same as putting up the analysis plan that was used, the assumptions, the actual data sets that you've gleaned out. I'm just asking about all those other elements.
Well, from our perspective, the proposal is posted online and the results that are reported in 1 year are reported online. So at least for investigators who are accessing this clinical trial data, you have sort of a record of what they've done and what they found.
Yeah, we can't require them to put every piece of R code or SAS code up there, nor could anyone else. But we ask them to agree not to redistribute the data. Again, the thinking is that anyone else can get to the data from our repository as well.